All right, welcome everyone. So if you are here for the first time and here to prepare for the board exams, which I presume most of you are, I want to extend before I begin a heartfelt welcome to the greatest field in medicine. And I'm not saying that just because I happen to be a practitioner of it. I 100% believe it. My life since I have become an obesity medicine physician has been completely different than the 10 years I spent in primary care. I go to work every day excited to go and see the amazing people I get to work with. And I said this last time I gave this talk, is that most of my day now, I mean, almost every patient I get to see, I have to spend significant time deflecting credit. I mean, how great a field is that, where you have to spend your day going, oh, no, it wasn't me, it was you. You did this. I just was here to provide some resources for you. But seriously, it's a fantastic field. Welcome to it. I'm excited for all of you as you begin in this wonderful, wonderful field. Okay, so let's go ahead and talk about the boards now. Obesity medicine treatment strategies. Disclosures here, and of course you've seen this before. Okay, so what are we going to talk about? We are going to talk about age-related treatments, prevention of obesity and weight gain, risks associated with excessive weight loss, management of a weight plateau, management of comorbidities, effective weight loss on those comorbidities, and some adult treatment guidelines, but we're going to kind of breeze through that last bit a little bit. I'm going to also try to add a little bit of clinical pearls here and there as we go through. Okay, so talking about the test, let's discuss some facts that I think are probably going to be pretty important. So BMI increases as you get older. Peaks during the 5th decade, so 50 to 59. And, but fat-free mass starts to decrease early, okay? And that's going to be important, especially for us, and we're going to talk a little bit here in a minute about sarcopenia, but we're going to be the people who are paying attention to this because we're the ones who are most likely going to be doing the body composition analysis. So watching people's fat-free mass as they lose weight is going to wind up being really important, and realizing that the decrease in this is earlier than most people think. Age decreases all aspects of total energy expenditure. So I think that's probably pretty important. It's not just the resting metabolic rate, though that decreases again earlier than many people would think. The thermal effect of food also goes down, and physical activity plays a huge role. And this is probably more significant for our patients who suffer from obesity because they're less likely to be comfortable moving around a lot. Okay, and obesity increases mortality, okay? I'm sure we probably all figured that, but yes, there is good facts and data behind that. Framingham data shows us that obesity at age 40, those people live 6 to 7 years less, so it's a significant factor. But this diminishes with age. So you look at people who are older, what you find is that the lowest risk BMI is higher in older adults. So when we get the very thin people who are older, a lot of times that is because they may be suffering from other conditions. So that may not be as big of a plus as people get older. So there is that difference that exists. Arthritis, again, leads to lower physical activity, and we get all these other additional problems that we'll talk about in detail here. All right, so obesity is associated with increased bone mineral density. And the thing that we need to be aware of is bone mineral density will decrease whether the weight loss is intentional or unintentional. So we might think bone mineral density is going to decrease in someone who is losing weight because of cancer maybe or some other illness. But if the person is trying to lose weight, even following a nutritionally sound plan with you, they have an increased risk for bone mineral density problems. And weight loss increases mortality, maybe. okay? So you'll read about this statistic sometime in the literature, but when you really go down deep, what you find out is that it's very unlikely that is going to hold true if the weight loss is intentional. So we've got two different things, intentional and unintentional. With bone mineral density, okay, you're going to have problems, intentional or unintentional. When we look and say, okay, if people are losing weight, especially as they get older, that can be associated with increased risk for mortality. There's a difference there between intentional and unintentional. And sarcopenia. Let's talk about this a little bit. So I just put it in here. I'm not going to read you the definition, but I think it's, again, important for us to be paying attention to this because you think, well, sarcopenia, I mean, loss of muscle mass, that is not going to be in our patients who suffer from obesity, but yes, often it is. And again, I'm going to go back to the fact that we're going to be the people who are paying attention to this because we are the people most likely to be looking at that fat-free mass through body composition. And it's going to matter in the advice that we give them because a lot of our older adults are actually protein deficient. And there's been a lot of questions in the literature over the last few years, how much protein is actually enough? And so for our older adults, we may be wanting to look at recommending higher than the current recommendations for protein. A lot of the literature now will say we want about 1 to 1.5 grams of protein per kilogram per day now. So I think that's probably a pretty important point. There's some evidence that leucine may be particularly helpful in this group, and creatine as well. Okay, so treatment differences in older adults. Exercise earlier may be beneficial. Okay, we talk a lot about exercise when it comes to weight loss. I mean, the data is not there that exercise helps with weight loss that much, but it certainly can help with maintenance. But in our older adults who potentially will be suffering from sarcopenia, we may be wanting to push exercise a little earlier than in some of our younger patients. Older adults are more compliant. They're less likely to have read whatever Dr. Oz had on TV that week, right? Or what they see on the internet. They're more likely to listen to you. And medication data is lacking in older adults, but I'll tell you, I use medication for my patients who suffer from obesity who are over the age of 65 all the time. And surgery can still be successful in this cohort. All right, prevention of obesity. Boy, oh boy, I wish I had the answer to this million-dollar question, really billion-dollar question, or billions of dollars. This is a very tough thing, right? And there are so many factors involved. So, general things, I think, here. Food policy. Our food policy must change. Sugar consumption. I presume everybody's probably heard the latest on this, right? I mean, sugar industry has been involved in, pushing sugar way back into the 60s, right? Blaming fat. Processed foods, nutrition labeling. And of course, as has already been pointed out, the sitting is killing us. And again, I'm going to push this in here again. I know that it's already been discussed, and I think the fact that you've seen this now a couple of times probably puts it up at the top of the list for things that I would know something about. Prevention of weight regain. Okay, no matter how your patient loses weight, this is a risk. I mean, I'll tell you right now, it's easy in quotes, to get people to lose weight. It's a lot more difficult to help people keep it off. So this is something that we have to be thinking about and talking about with our patients from day one. And so first thing when it comes to weight regain is, what does it even mean? There's not one consistent definition. So here are some that are very often used, and so I think it's very important to be familiar with all of them. So, most common that we see is a loss of 10% and maintaining this for a year. That would be considered weight loss with maintenance. The National Heart, Lung, and Blood Institute have a different definition. And then another one, we're going to talk more about this because, again, I think this is another incredibly important thing to be familiar with, is the National Weight Control Registry. They define it, and I would really know this, 30 pounds loss and keeping that 30 pounds off for at least a year. So the big difference for there is it's a specific number and not a percent. One-on-one contact has been shown to be superior. Prepackaged food actually correlated with worse compliance over the long haul. And longer-term maintenance follow-up has been shown to be helpful. How long do we need to stay with these people? 2 years? Nobody really knows. What I always tell my patients, just, clinical pearl, is I'm with you forever. I actually hope I don't work forever, but someone will be there at my clinic forever with them. I don't want them to ever completely go away. I mean, our checkups may be very infrequent, but we want to be touching base with them. And potentially some strategic uses of medication. So you're going to hear a lot about medications for weight loss, but what about medications for weight maintenance? And that may be something that we should be talking about and considering more. So for example, like phentermine. I have some patients who are in weight maintenance, and we use phentermine for a month every 6 months as a weight maintenance plan. So there are some potential utility to these types of approaches, even in the long term. Okay, so I am actually just going to touch base very briefly on this because this is a highly contentious subject, and there is going to be some discussion of this in the regular conference. Set point theory is very controversial. What we do know is that resting metabolic rate and T3 will decrease in energy restrictions, but a lot of times these have been found to rebound after the significant energy restriction is lifted. And exercise seems to make a difference here. All right, so let's go back to what I said already was pretty important, and that is knowing some details about the National Weight Control Registry. I mean, really, I think this whole slide here is important. Criteria, again, we already talked about. This is very different than other criteria because this is a number, know that 30 pounds. And so what else do we know about these people, right? So half of these people lost weight on their own, half on a program. And this list of predictors, again, very important. And one of the things that we want to point out again, exercise, not shown to be all that great for weight loss, but look at this when it comes to weight maintenance. It is pretty important here. And so that's very highly correlated with success in this cohort of people. All right, so medicines. So I know there's a whole section on pharmacology, but I think it is definitely worth mentioning again about these being a huge problem with weight regain. I'll tell you, I was just doing a research rounds a couple hours before coming down here, and once again shaking my head at what people will get put on by other physicians. So today we're dealing with a weight gain from a patient who was put on only 10 days of prednisone for seasonal allergies. Never mind the fact that she's diabetic and has just lost 70 pounds and is feeling great about that, but someone put her on that, and these are things that are going to happen all of the time. And it is super important that you're constantly looking for this, asking questions, because it's amazing that other physicians will not be thinking of this, and the list of medications that can sabotage your patient is long. And these are very often places that you can intervene and say, I understand the thought process behind this, but let me place a call to that physician and see if maybe there's another medication that would be a better fit here given your goals. Again, and the list is very long. So I actually wanted to talk about a little case study here as an example of how important this can be. So this is a patient of mine, 61-year-old female with metabolic syndrome, no history of coronary artery disease. And that's going to actually wind up being an important point here. She was on a low-carb, high-fat diet with me. She had lost 55 pounds in the past year and plateaued. She was on a Tenolol 100 milligrams for years. So we kind of looked at the plateau. As I do with plateaus, go back to their med list. That's one of the first things that we do after listening to their food diary. And we said, well, let's try to work off this atenolol. Now, remember, I said she had no history of coronary artery disease, right? That's an important thing to know, because if we're looking at a beta blocker, are they on it for any other reason? They got AFib? Is there any other? No. With this lady, it wasn't. This was just hypertension. She wasn't on lisinopril either, and so some really good reasons to make a change, especially with that metabolic syndrome history. Nothing else changed, right? She'd been doing the same thing. She was really good, no changes in her diet. This is what happened in the first month when we made that change, 9 pounds. And continued loss at this, but she broke through her plateau, lower level. She didn't continue to lose that high of a rate every month. But my point is, beta blockers can be a big deal with weight. I see it all of the time. So this is just a little slide here talking about gain with beta blockers over time. Again, a very underappreciated problem for our patients. And sometimes there's nothing you can do about it if they've got a history of coronary artery disease. But if this is just straight up hypertension, there's probably a better way to go about it. Okay, so now let's talk about risks associated with excessive weight loss. With first, it's like, what do you mean risks? I mean, weight loss is great. Yes, but there are some things that we want to consider. All right, so first about obesity paradox, right? So is there an obesity paradox? Well, maybe. So let's kind of look at some of the data here. So when it comes to hypertension, okay, we've got over 22,000 patients with hypertension, known heart disease over 2 years. They had a 30% lower all-cause mortalities in patients who suffered from overweight and obesity, despite even the fact that their blood pressure control was less. And in heart failure, same thing if we can take a look here at the graph. So the question is, wait a minute. That doesn't seem like initially it would make sense. But it continues, actually. After revascularization, higher mortality with extreme obesity, but obesity strongly associated with first non-STMI occurring at an earlier age, but also prolonged survival after the revascularization. Peripheral artery disease, the same. So I think it is important that when people ask about could there be an obesity paradox, I mean, there is some evidence for this. Now, last year there was a paper that kind of looked at this that said, okay, let's take another peek at this and say, is this really a paradox or is there more going on? And so right here you can see the conclusion. So basically it is, yes, the data is there. There does seem to be this surprising obesity paradox when it comes to cardiovascular problems. But likely there are other things going on. And bottom line of this study is, we need to look further into this. So I think, though, for your purposes here, it is important to realize that there is an obesity paradox, but we don't fully understand it. So should patients stay obese, right? If there's a paradox here? No. Patients affected by obesity have a 50% increased risk of developing AFib. That's a biggie. And I think we've already talked about this. Again, I'm going to go back to the fact that 2 people have brought this up, some of these statistics, so it's probably pretty important to commit to memory. Higher sudden cardiac death, even in seemingly healthy patients with obesity. So I'm going to go back to something that was just discussed too, and specifically on this one. And I will tell you that I believe that this is very likely because of some of the QT abnormalities that we see in these patients. So I'll tell you my little clinical pearl. Patient comes in, I screen everybody on entry into my clinic with a EKG. We catch QT prolongation all the time. They can be on a litany of medications that can be problematic with this. I throw them on magnesium and it gets better. So that's just a little clinical pearl. And we can see prolonged QT very common in these patients. Increased electrical irritability. Again, I still think that these are all related. Sleep apnea. And studies suggest that if fat mass is lost instead of lean body mass, mortality lower. Going back to that study that I was just showing you the conclusions on. Is there really a paradox? Is there something else going on? Okay, so now let's talk about risks with weight loss bone density. what I told you already, again, and I think is very important, is that bone density problems come about whether the weight loss is intentional or unintentional, but exercise matters on this. So when it comes to exercise, I think it is very important to understand, okay, what is exercise going to be good for? Maybe just as important when you're talking to your patients to understand what it's not going to be as good for. But one of the things that we can really push them on, especially with a history, family history of osteopenia or osteoporosis, is it's going to matter in the long run as you lose weight and that bone density is likely to decrease. It's going to decrease less if you're exercising. Okay, gallstones. So I know this, again, was already touched upon too, but one of the things to remember is in these people who have had cyclic weight loss, one of the things that you will find has happened with them is that they have had periods of significant fat restriction, because in the past, that's how people always tried to lose weight, right? They'd go on these low-fat, sometimes extreme low-fat diets. And if we think about our gallbladder, right, we can see why this is a problem for gallstones. Because the gallbladder's job, right, is when you eat fat, it squeezes. If you're not eating fat, it's not going to be prompt to squeeze. So you get all the bile acids sitting in there for a long time because there's no fat coming in, and they can form stones. So what I say is one of the treatment for prevention of this can be ursodeoxycholic acid, and the other treatment is get them to eat some fat. Okay, that works too. All right, so risks associated with excessive weight loss, kidney stones. Two big things with kidney stones to be aware of. The very low-calorie diets have been shown to be associated with kidney stones, and ketogenic diets. Most of the evidence for this is in kids. In adults, it's more theoretical, but as someone who uses a ketogenic diet all the time, I think probably this is true. Okay, and gout. Again, we know there's a very strong association of obesity and gout. And one of the things that I think is going to be very important to know, a little factoid here, is when it comes to gout, the higher uric acid is also associated with hypertension. So it's been shown really nicely in studies on teens that when you get high fructose, which has been shown to increase uric acid, this is associated with hypertension because that uric acid affects nitrous oxide in the vessel and makes the vessel stiffer. So again, I would associate uric acid with gout, but I would also know this little tidbit about it being associated with hypertension as well. And then another important fact with gout is with ketogenic diets, because it has been very well documented that when a patient begins a ketogenic diet, initially, over about the first 8 weeks, uric acid levels will rise quite consistently. Now, this is because both are competing for excretion at the level of the kidney. And this is temporary. So this is a temporary rise. That's also important to know. So if you see a patient, or if you're using a ketogenic diet on your patient, they will have an increase in their uric acid level, but this will very predictably fall at about the 8-week mark. Okay, loose skin. So this is a big problem for patients. And first we just think of loose skin as going to be a cosmetic issue only, and that's actually not true. What I see this cause in patients all the time is balance problems, especially in these men who had these huge protruding bellies, and they lose, and the skin winds up falling to one side more than the other. And here's the interesting clinical pearl here. Medicare does not care about this, okay? They don't care at all if your patient can't walk or can't do anything because the skin is pulling and causing balance issues. All they care about is if it's causing skin integrity issues. So do your patients a favor and start documenting skin integrity in these people early on. Because if you can prove that they've got integrity issues and you have tried to treat them with at least one prescription medication and it has failed, we can get Medicare to cover the surgery for this. But balance is usually the bigger issue, but it's not going to help you with coverage. That's just a clinical pearl. Okay, polypharmacy. Okay, so this is actually what I would consider your biggest job. As your patient loses weight, they need to have someone who understands how to take medicines away. And let's think about this for a minute, right? Because how many of you learned in medical school how to remove a medicine? No, nobody did that, right? You only learned how to prescribe more. Welcome to the field of doing things differently. This is one of the things I love most about my job, because in primary care, I was what? I was like a prescription hound. I mean, you came in and all you did is you got a no pill for something, another problem, another pill. And I am much more likely in my new life, it's not so new anymore, to take away medications than I am to put people on it. But you've got to know how to do this, because this can be a huge safety issue for patients, especially with diabetes. Because quickly, as your patients lose weight, they will be over-medicated. Synthroid, we must remember, is a weight-based medication. So when patients come in, I kind of always try to prep them for this ahead of time. I'll say, look, what we are going to do here is not going to fix your thyroid. It's not going to make it better. I'm not going to make it worse either. But you may need less medicine because as you lose weight, the weight-based nature of Synthroid is going to be a factor. Again, always telling them, because they'll come in and say, it got better, my thyroid got better. No, it didn't. Antihypertensives, again, you want to catch people who are over-medicated because of weight loss before they hit the floor. GERD medications, again, something that people get put on all the time, right? Get put on it by who knows what kind of physician, and then nobody ever goes back to say, is it still necessary? That's your job. As they lose weight, it's probably not. Cholesterol-lowering medications, especially those that are for triglycerides, we can get rid of those like crazy. IBS medications, pain medications, and again, it's last here, but it is the single most important one because it is a safety issue. We have to be cautious about diabetes medications. Okay, causes of a weight plateau. So, this can be so multifactorial, and of course, nutrition is the first thing. I go through a food diary with everyone, but again, up at the top of the list here I put, because it's so important for us to recognize this, is go back and see what somebody just put them on. Are there other metabolic non-diagnosed issues? Sleep apnea is a big one here. Thyroid, rare issues, but we do see them, growth hormone deficiency or excess, Cushing's. Behaviors. One of the behaviors that we don't think about is patients just get a little overconfident. They think they've got this, and then they don't realize what's sneaking back in. And then psychological. Boy, if I could, tell you something that you must be paying attention to with your patients, it's this. Because again, it goes back to the idea that we think all weight loss is wonderful. But it's different. And it's taking patients away from something that, although they saw as negative, they've been comfortable with. They've been comfortable with the idea of being someone who suffers from obesity. And if that's changing, you've got to help them be comfortable with a new perception of themselves. And I can't tell you the number of times that I've seen patients sabotage themselves because they've been put out of their comfort zone. So be aware of that and be open to discussing it. Diabetes. Okay, so here's just some facts. This slide is kind of full of facts that I think would be important to know. And let's talk about this more. I would also know a lot about the ADA guidelines, but full disclosure, I totally disagree with all the ADA guidelines. But know them, okay? It's important. What should exercise include? Know these exercise recommendations. And again, the ADA believes there is no ideal percentage of calories from carbs, proteins, or fat, despite the fact that carbohydrates are what's causing the problem. Macronutrient distribution to be based on individual assessment of current eating patterns, preferences, and metabolic goals. So if your patient has a metabolic goal other than good control, great. But my patients have goals of good control or resolution. Again, eating patterns that the ADA is currently recommending. Interesting variety there. And let's talk about diabetes in the way that I treat it and I think is the best method to go about it, which is a low carbohydrate or a ketogenic diet. And many of the times in our patients, if we can pull away carbohydrates from them, they will wind up resolving their diabetes. They require no medications for normal glycemic control. And, you know, there's a lot of discussion now as low carbohydrates being our first-line treatment. I do believe fully that it should be. We can pull patients off hundreds of units of insulin, again, with normal A1Cs. In type 1 diabetes, clearly low carbohydrate intervention is not going to solve the problem, but it can make their quality of life much better because it can keep them from having so many excursions. So I want to talk about diabetes case study to really hammer home on the fact that as I said before, I consider this your most important job, learning how to take medications away from people before they get into safety trouble. All right, so this is a case study of mine. So a 74-year-old male, type 2 diabetes for 10 years, came in on 60 units of Detromir, 100 units of gliptin, and hypertension medications, hydrochlorothiazide, amlodipine. A1C was 10 on this. Creatinine 1.4, as you can see, his triglycerides were elevated as well. So clear problems with his triglyceride HDL ratio, and this guy's got metabolic syndrome. Lipitor 40 milligrams, sleep apnea, uric acid elevated, and with the medications he still wasn't currently well controlled. Okay, so of course, what do? You know, notice this guy, again, coming in, this medication reconciliation is part of your job. You know, he's got elevated uric acid, get him off the hydrochlorothiazide, put him on an ACE inhibitor. He's not on metformin either, right? That's going to help him on many levels, and although his creatinine is elevated, it is not elevated to the degree that we can't use this. So we added metformin as well. So what are the things that we could consider in this patient, right? We could consider a low-fat diet. Calorie restriction would be required for that. It will likely worsen his already elevated triglycerides, okay? Important point. Weight loss with a low-fat diet would modestly improve his A1C, so would do so slowly, so we'd have less stress about having to worry about that insulin right away. We could also use a Mediterranean diet. Higher fat will improve the triglycerides. Wide variety of food choices, maybe cardiac benefit. Less rapid med adjustment too, maybe a little bit quicker than the low-fat diet, okay? But probably not any major overnight changes. We could put them on a very low-calorie diet. There's adherence concerns in this, especially in the long term. A1C improvement, rapid medication adjustment required. And then there's the low-carb, high-fat diet. It'll improve his triglycerides. Multiple studies will show glycemic improvement, and rapid medication adjustment required. So let's see what happens. So I put him on a low-carb, high-fat diet. 2 weeks later, we had already decreased his Detromir to 40, I took him down to 40 the very first day. So knowing that I was going to carb restrict him, I immediately took him from 60 to 40. Day he started changes. And 2 weeks later, I had already decreased him again to 30. Fasting blood sugars are running just over 100 now with postprandials in the 130s. Now, remember, this guy came in to me with an A1C of 10. So this has been a rapid drop. This is too low right now. Of course, it's ideal. We want them to be there, right? But not while he's currently losing, restricting carbohydrates, and still on 30 units of insulin. So we've got to take him down even further. And then he was to call readings to me in a week. And here we go. Look at what's happening. So 30 units at night, and here's the carbs he was giving me, total carbs that he was eating every day. So he was restricting really nicely. 3 weeks later, blood sugar average on the 25 units of insulin, 134, fasting and postprandial, with the average on the meter, lost 5 pounds total. So it's not that he's had this huge weight loss, right? But his diet totally changed. We put him on exenatide and decreased his detromer to 10 units. So I use exenatide or other GLP-1s as bridging to help people get off insulin. So thoughts on this, and again, this is another important point here, is thinking about those medications and weight, right? I mean, why would I want to put him on a GLP-1 over insulin? Because insulin is a weight-positive medication, right? It's also putting him, the longer he stays on insulin, the more risk he has with those blood sugars dropping too low. So the quicker I can get him off of that, the more we can both relax. Weight neutral medications, the DPP-4s, okay, and weight negative, again, GLP-1s and often metformin as well. So those are important points there as far as weight and the medications go. Okay, so again, more blood sugar readings. Look at this. We got to finally stop. We went down to 5 units, and then we stopped his insulin completely here after just a few weeks. Next visit, lost over 5 pounds, so his weight loss actually picked up right as soon as we got him off the insulin. Blood sugar remained great. Pull him off exenatide very soon. Actually, this has been a while ago. He's been off of exenatide. He's been off of all medications now. This is a guy from 2 years ago. He has maintained an A1C in the non-diabetic range off of every medication. 2.5 months, off 60 units of insulin. Weight loss, again, picked up after insulin removed. We already mentioned that. His A1C was 6.6 at that 3-month, or just before the 3-month. But like I said, this guy is now a 2-year success story. Normal glycemic parameters off all medications. Properly managed diabetes medications as patients make lifestyle changes. So important. Understand them. Know the mechanisms of actions. Proper follow-up is essential. Make the proactive decreases depending on what kind of nutrition intervention you're doing. Going back to those slides where I gave you all the options of things that we could have used, know what you're going to have to be more alert about. And I'm going to talk more about this, so I'm going to skip over this in my obesity and lipids lecture. But this is how I describe metabolic syndrome to patients. I like to talk to them about it as a tree with the trunk, which we can all affect, being those elevated insulin levels. Metabolic syndrome, again, another important tidbit, not only knowing the criteria, but another thing is be familiar with that triglyceride HDL ratio. You know, right now we are concerned when it becomes over 3, although I think, honestly, the literature is going to be changing on that, and we need to start getting excited, in clinical practice at least, when it hits over 2. Sleep apnea. Everybody, I think, has talked about this quite a bit, so I'll just leave the slide up here and let you guys review that later. And again, more little ghrelin-leptin ratios. I know this has also been discussed, but again, this is another tidbit. Know that sleep apnea is more than patients being fatigued. It can absolutely directly create problems for weight loss. Hypertension, again, be careful with your patients on lots of hypertension medications as they lose weight. You want to be constantly asking them, are you getting dizzy when you stand, okay? And if that's the case, we want to start decreasing these medications too. A 5% weight loss alone can start to impact blood pressure. All right, fatty liver disease. So this has also been touched on a little bit, but I wanted to bring this up as it relates to children, okay? This is data from a 2006 study, okay? I mean, we are having problems with fatty liver disease in kids as young as 2. So the data from this 2006 study showed us that almost 20% of kids have fatty liver disease before they graduate from high school. And that's an old study, older data. We know it's worse now. But this is the most recent study that I've been able to come up with that has really good, hard numbers. So realize, again, for your purposes, that fatty liver disease, yes, it affects adults, but it's also affecting kids, really young kids. And as we can see, it's also then affecting their life, okay, and life expectancy. So very, very, very sad graph right here. Again, fatty liver disease, you're going to be seeing it all the time in your kids. Pathologically, another thing, if there's a pathology, pathologically, question, this is the same as alcohol liver disease, okay? That's an important thing to know. And you can reverse this. This is something that you guys can help patients recover from as long as we get it before it becomes cirrhosis. Okay, so cholesterol. Honestly, weight loss and cholesterol is a very complicated subject, and what happens to cholesterol can really depend on what you're doing nutrition-wise for patients. So realize this, the changes can be different. So low fat and low carb impact cholesterol parameters differently. So I would just kind of take a look at this graph and know it. I'm going to be talking a lot more about this on Friday. And this is a nice graph taking a look at kind of the three most common, dietary interventions you'll probably see: low fat, Mediterranean, and low carbohydrate. Again, this graph really showing that there can be very different cholesterol results depending on the nutrition used. And one of the surprising things in this is that people always think that the low-carb, high-fat diet will, negatively affect everyone's LDL cholesterol, and actually in studies that doesn't pan out to be the case most of the time. Again, when it comes to cholesterol, I think that this is part of what we are responsible for, okay? Because it, number one, changes as people lose weight, and we need to understand the risks fully. I don't want to go into this too big in detail. I'm very excited to present you kind of my vision of the cholesterol world on Friday, but it is important to understand that LDL-C, which we have always relied on to assess risk in our patients, is very ineffective in patients who suffer from overweight and obesity because of insulin resistance, okay? There's been calls now that we probably need to be doing this very differently, and that is because an LDL-C can be carried in many more particles in patients who suffer from obesity and have insulin resistance. So if we just go by LDL-C and we don't actually look at the number of these problematic particles in our patients, which is LDL-P or LDL particle count, we miss risk in a lot of people. Okay, so cholesterol is another important thing for us to understand is statins increase the risk of diabetes, okay? This does not in any way, shape, or form mean we shouldn't be using them in appropriate people. But you do have to understand that there are risks associated with it, and a lot of people don't appreciate just how significant the increased risk of diabetes is. Genitourinary, these are problems in our patients. Reproductive problems, again, I know these are covered more by other people. And depression. Again, we talked a little bit about people becoming comfortable with themselves. Depression is something we want to always be talking to our patients, screening for when it comes to people who suffer from obesity, but also as they lose weight. Again, thyroid, I know that this has also been discussed, so I'll just kind of breeze over this. And again, slides that I put in here in the talk are things that I think are very important for your testing purposes. So go ahead and take a look at these more on your own. I think I am running out of time here. So, and again, sample questions, I'll let you guys do those on your own. Thank you very much.